Hi, everyone, and welcome to today's program on hereditary neuropathies, including amyloidosis and genetic testing, featuring our expert speaker, Dr. Florian Thomas. This webinar is being hosted by the Foundation for Peripheral Neuropathy and is generously being sponsored by Alnylam Pharmaceuticals. My name is Lindsay Colbert, and I am the Executive Director of the Foundation for Peripheral Neuropathy. I want to thank everyone for joining today and expressing interest in this program. We really appreciate you trusting us to provide educational information on hereditary neuropathies and genetic testing. Before we get started, I want to let everyone know that this presentation is being recorded and will be shared with you via email within the next 24 hours. The recording, along with the PowerPoint slides, will also be uploaded to the Foundation for Peripheral Neuropathy's website for future reference and viewing. At the end of the presentation, we will open up the floor for live questions. Please submit those questions through the questions box located in the dashboard of this platform. I ask that you please keep your questions specific to the topics and avoid any personal medical questions, since we'll not be able to answer those questions during today's program. I'm also excited to share that we surveyed our patients before this program about the topic of genetic testing. Thank you to those who took time to answer the survey, as it allowed us to better focus today's program. On this slide and the following slide, I just am going to quickly highlight the two survey questions that I personally found to be really interesting. And we're going to be sure to cover these misnomers later on, but I just wanted to share these survey results with you. Next slide. If you're interested in viewing all the results from the survey, please feel free to reference the file that we uploaded to this platform. It's also going to be referenced on our website alongside the recording. It's in the handout section. And now I'd like to introduce our expert speaker for today's talk, Dr. Florian Thomas. Dr. Thomas is a board-certified neurologist with expertise in spinal cord medicine, neuromuscular disorders, neurogenetics, and neuroimmunology. He treats conditions like ALS, MS, peripheral neuropathies, and spinal cord injuries. As chair of neurology at Hackensack University Medical Center, he has led the development of various neuroscience programs. Dr. Thomas has also directs Centers of Excellence for Hereditary Neuropathy and Charcot-Marie-Tooth disease. He actively engages in clinical trials, collaborates with organizations like the National MS Society, and received the recognition for his contribution to MS care. And with that, I'd like to pass the virtual mic off to you, Dr. Thomas. Thank you again so much.
Thank you, Lindsay. Great to talk to this large group of people interested in hereditary neuropathies. As Lindsay had referred to, hereditary neuropathy are the largest part of my clinical practice besides multiple sclerosis and spinal cord injury. And I've engaged in clinical work and research on hereditary neuropathies since the late 1980s. Can I have the next slide, please? No disclosures. I love that little slide there from the Charcot-Marie-Tooth Association. And the next slide, please. So just to put everybody on the same page in terms of the organ in the body that we are focusing on today, the peripheral nerve. So this is a prototypical peripheral nerve axon, axon being the wires that connect the spinal cord and the brain to muscles, internal organs, and the skin, as well as bones. You see these little corn dogs like structures. Those are sections, very tiny sections of each nerve that have received insulation material from the so-called Schwann cells, which produce myelin and are wrapped around each axon to insulate it from adjoining axons. And depending on the structure of the myelin or the myelin sheath, its presence changes the speed of electrical conduction from something like 5 meters per second to 50 meters per second. And different types of nerve fibers conduct at different speeds And that's important because, for instance, sweat glands are innervated by nerve fibers, but those nerve fibers are pretty slow. They don't need to be fast. Whereas when nerves connect to muscles, those fibers conduct at 50 meters per second. And in health and in disease, the speed of conduction is very important, both in terms of nerve functioning and in terms of making a diagnosis of a particular neuropathy by electromyography and nerve conduction studies. So what do these nerve fibers, what kind of information do they carry? Essentially three areas: sensation, such as vibration, temperature, joint position sense, which we also call proprioception, pinprick, and light touch. For the motor fibers are responsible for strength and for the size of the muscle, for the bulk. And we'll talk about that more. And I'll show images of people who, due to a hereditary neuropathy, have lost a lot of muscle bulk. And then there is the autonomic function. So autonomic refers to bodily functions that are under limited control by the conscious, awake human being. We don't typically control our blood pressure. We don't control whether we sweat. We don't control whether our bladder is filling up. We don't control what our gut does, and we don't. In some areas of sexual function are not under conscious control. Can I have the next slide, please? So, focusing on hereditary neuropathies, they've been recognized for almost 200 years. The first descriptions date back to the 1850s. The first descriptions that gave rise to the name Charcot-Marie Tooth are from 1885 and 1886. And over the next 150 years, we've learned a whole lot more. So in 1939, we recognized that people with unaffected parents and neuropathy often have severe neuropathy. We'll talk about that later. That's autosomal recessive. We learned that some males have neuropathy. Their fathers are never affected, but their mothers are affected. That's autosomal. That's X-linked recessive. In the 1950s, a protein accumulation disease that can affect every organ in the body, but specifically the nerves, the heart, the kidneys, and the eyes, was recognized as hereditary amyloidosis. In the 1960s, the technology that I just referred to, EMG nerve conduction studies, was developed in the United Kingdom and the United States, and that allowed us to differentiate axonal CMT2 from the myelinating CMT1. The difference being that in axonal CMT2, the speed of conduction is relatively normal, whereas in demyelinating CMT1, it's dramatically reduced to a third or half of normal. So not 50 meters per second, but 25 or 15. In the 1980s, we first recognized that people with abnormalities consistent with hereditary neuropathy have linkages to an abnormality on 3 chromosomes initially: chromosome 1, 17, and the X chromosome. X chromosome is of what women have 2 and men have 1 in addition to a Y chromosome. In the early 90s, 5 genes were identified, and I had the privilege of describing the first microscopic changes in a father and son who had a mutation on chromosome 1 due to the myelin protein 0 gene. And that number grows rapidly. And every year we add about 3 new disease genes. So in 2006, my group added 1 disease gene now referred to as YAS. So now we are at 120 easily testable genes, and the number is growing dramatically. As that little pie chart shows, those 120 genes are not equally distributed. Some are dramatically more common as causing diseases than others, and we talk about that more. Can I have the next slide, please? So going back a little bit to the classification, we talked about CMT1, CMT2, we talked about the gene that I identified, we talked about X-linked recessive conditions and several others. So it's a little bit difficult to read, and we don't need to go through the details, but there are conditions in which sensory motor fibers are equally affected, and there are conditions where it's mostly sensory and autonomic fibers, and there are conditions where it's mostly motor fibers. Those are certainly less common, but those differences exist. There are conditions that are inherited when an affected parent has a child. We call that autosomal dominant. There are conditions that are inherited when two unaffected parents who each have one bad copy of the gene, which is not sufficient to give them disease, have a child that inherits one bad copy from either each parent and therefore has two abnormal copies. We call that autosomal recessive. We talked about X-linked recessive and so forth. The presentation is also a distinguishing factor. Babies can be born with a very severe hereditary neuropathy. We call that congenital hypomyelination neuropathy. Toddlers can develop that. I see 3-year-olds with obvious CMT. People in their teens, their 20s, their 30s can first develop symptoms. I'm thinking of a woman who danced ballet in high school, and as she entered her 20s and started to attend weddings of her peers, she noticed that every year the heel size that she could wear decreased by 1 inch. And she recently sent me an email because she won a big award, and she remembered our discussion and told me that for that event she was going to wear sparkly flats because she's certainly not able to wear any heels anymore because of foot weakness. And late onset neuropathies are of particular interest because when people are in their 60s and 70s, they typically have accumulated other conditions that can cause neuropathy. We'll talk about that more. But we recognize now that there are also hereditary conditions that can only start that late. And as I said, we differentiate based on nerve conduction studies. The speed of conduction is an important factor. Can I have the next slide, please? So I like this picture of 2 trees from New England Journal 1992, which shows that, which is a good illustration of what happens to diseased nerves. They die off at the top. And it doesn't make a whole lot of difference why those nerves die off. It doesn't matter what is the gene that's mutated. The final common pathway is that something goes wrong initially at the longest nerves. That's why people develop symptoms in their toes before their heels, symptoms in their heels before their fingers, symptoms in the ankle before it goes to the wrist and so forth. That's also why proximal strength, shoulder girdle, thighs are usually normal unless one has a really severe hereditary neuropathy. The slide that's kind of shaped like an alligator with its tail at the bottom shows what those 120 genes, although we're only showing a small minority of them, do in the peripheral nerves. Some are responsible for the myelin sheath to be tightly wound around the axon. Some are responsible for small molecules getting through the myelin sheath, and other genes are involved with maintaining the length of the axon. An axon in a 7-foot basketball player can be about 4 feet. That's a very long structure to maintain. Some have to do with energy metabolism. If there is insufficient energy at the tip end, at the long end of the nerve will die. So there are multiple mechanisms. And when we think of treatment, experimental treatment, at this point, most experimental treatments that are being designed, none of them are on the market, except for amyloid-related conditions, they focus on a particular abnormality in a particular gene, as opposed to on all genes. That's a much more complex task. And that also means that for people with rare forms of hereditary neuropathy, it's much more difficult to design clinical trials because there might only be 200 people in this country who have the same condition. That's why drug treatment is still in its infancy, except for amyloidosis. Can I have the next slide, please? So talking about amyloidosis a bit more. As I said, the mechanisms of disease, how does a mutation damage the nerve, varies significantly across the different subtypes of hereditary neuropathies. With amyloid, and of course, people in the audience may have heard what amyloid accumulation does to the brain in terms of Alzheimer's disease. It is actually quite similar. If a protein is misshapen, as is the case with amyloid, it cannot be broken down by the body. It can accumulate, and accumulation of proteins can damage the cell. Just to give you another example that some of people in the audience may have heard about, in Parkinson's disease, we describe Lewy bodies. Lewy bodies are accumulations of protein that damage the cell. So the question is, how does one get rid of such accumulated proteins to preserve the cell? And we'll talk about that a bit later. Can I have the next slide, please? So this is pretty much a repetition of what I already referred to, as that is the different modes of inheritance. So if you look at the upper right corner, autosomal recessive, you'll see that the circles are females, the squares are males. Two unaffected parents have one affected female child and one unaffected male child. In X-linked recessive, three generations are shown, bottom right. There is an affected male who passes on one X chromosome to his daughter, and the daughter gets a normal X chromosome from her mother. The daughter is affected, and she passes it on to her four sons who are affected. And we can skip over the others. Can I have the next slide, please? So just to put things into perspective in terms of how common various types of neuropathies are. Worldwide, and that's been known for almost 60 years, since 1973, about 1 in 2,500 people have a hereditary neuropathy, which means for the United States that there are about 140,000 people who have a hereditary neuropathy. Half of those have CMT1A, which affects 1 in 5,000 people. Overall, only about 7% of all neuropathies are inherited. The vast majority are not inherited, and they're caused by conditions such as diabetes, which is the single most likely underlying disease to cause neuropathy. Essentially, after 10 to 15 years, all diabetics have neuropathy, and of course the prevalence of diabetes is something like 30%. It's not just established diabetes, but also pre-diabetes or glucose intolerance, also known as impaired glucose tolerance, which causes neuropathy. We'll talk more about how I approach patients who come to me with neuropathy to find causes. We talked about CMT1 demyelinating, CMT2 axonal, axonal meaning a relatively normal conduction speed, CMT1 very abnormal conduction speeds. CMT1 is much more common. 2/3 of people have CMT1, 1/3 CMT2. Among the common forms of neuropathy, as stated, CMT1A affects 1 in 5,000, CMTX1, the one that is passed from males to their daughters and from the daughters to their male sons, affects 1 in 50,000. There's one axonal type of neuropathy, also 1 in 50,000, and CMT1B, one of the earliest ones to be identified, also 1 in 50,000. Autosomal recessive is really rare, except when you go to communities where there's a lot of intermarriage, cousins marrying cousins. That is, for instance, the case in a town that I visit. I'll show some slides in Bulgaria, where half the population belongs to the Roma tribe, Roma group, ethnic group, and there's a lot of intermarriage. So in those populations, autosomal recessive can be quite common. The condition that I identified in 2003, 2006, due to Yas mutation is very, very rare. I still have only identified 2 families, one in Bulgaria, one in the United States. So with something like 50 affected people, very, very rare. There's another type of hereditary neuropathy, which was only identified some 6-7 years ago due to a mutation in a gene that codes for the sorbitol dehydrogenase protein. It affects 1 in 100,000 people. And the amyloid mutations are even rarer, 1 in 1,000,000 people. So Ms. Colbert had said that there are about 500 people in the audience right now. With an overall prevalence or frequency of 1 in 2,500 people, one would need to have an audience of 2,500 patients to identify one person with a hereditary neuropathy. What does that mean? It doesn't mean a whole lot. I still test pretty much everybody who comes to me, but of course, since hereditary neuropathy is my main clinical condition, most people who come to see me with that particular question or with an already established diagnosis of hereditary neuropathy. Can I have the next slide, please? And by the way, Lindsay, if there are any questions in the chat, feel free to interrupt me, and I'll be happy to take questions from the audience as we go along. So what I'm showing here, starting with the pictures at the bottom, so the 2 hands on the left lower corner are from a person that I encountered in Bulgaria who has an autosomal recessive neuropathy. As you can see, he cannot extend his fingers because they're so weak. The middle panel shows a daughter, a mother, and a great uncle, also in Bulgaria, from the families that I have studied. They have an autosomal dominant condition, and you can see that the daughter has more muscular calves than her mother, and the mother has much more muscular calves than her great uncle. You can see how shrunken the foot dorsiflexors and plantar flexors are. And the panel on the right shows the family with the same mutation as the family in Bulgaria, 2 generations, and the only person, so between the ages of 10, there's a boy on the left, and 40s to 50s, the only person, and you kind of guys can guess who that is, who is one of the sisters of the rest of the group, this gentleman had 13 children, is the woman with the black pants who cannot pull her pants up to the knee. She can't pull them that high because she has normal muscle bulk in her calves. And you can see how everybody else has very skinny calf muscles. So that's a hallmark. And sometimes we refer to that with the term champagne glass feature of the calf muscles, or inverted champagne bottle. Skinny ankles, but more muscular calf muscles just below the knee. So going to the symptoms and signs, nerve conduction nerve dysfunction causes distal weakness, atrophy, sensory loss, and poor reflexes. If you've been to doctors, they might have checked your ankle jerks, your knee jerks. Typically, not always, they're diminished in people with hereditary neuropathy. There's weakness, which starts in the toes, in the feet, before it reaches the hands. The weakness also causes the interplay between bones to change. That's why people have hammer toes, where the toenails don't point upward, they point forward. High arches is another feature, flat feet as well. And in terms of the hands, the standard question we ask, do you have trouble turning keys, opening buttons, opening, closing zippers, closing clasps, dropping things, tying your shoelaces, and so forth. Balance can be impaired because people don't feel where their feet are. So especially if they wash their hair in the shower and have their eyes closed, that is a risk for falls. And of course, fractures or head injuries. So that's all, it has to be taken very seriously. Pain is not rare, it's rarely severe. So the neuropathic pain in diabetes is much more prominent in most hereditary neuropathy. There are certainly exceptions to that than in CMT. Disability can be significant from that family with the 13 children. Of the grandchildren, there are two who had to stop working, one as a tool and die maker, the other as an optician, because they couldn't hold tools anymore. There is some evidence that after age 50, condition progresses faster and people with CMT often retire earlier. Living with a chronic illness, whether it's cancer or heart disease or stroke or hereditary neuropathy, can affect the mood. And that's why in our program, I employ 6 psychologists. So that needs to be addressed. People are afraid of falling, obviously. That fear can affect the mood and can lead to social withdrawal. It interferes with professional life. And often I ask my patients, have you informed your employer of your condition? If you don't inform your employer, you can't get reasonable accommodations, but you may be concerned about the consequences of informing your employer. Disability can be significant. I took care of women who were going to thinking about having babies, and they were afraid, would they drop their babies? Would they have trouble opening, closing diapers? And there's some suggestion that CMT can progress faster during pregnancy. Can I have a next slide, please? So we talked about this already. These are some of the hand functions that are affected. And the next slide. Onset age is highly subjective. One example, the 5-year-old oldest daughter of the gentleman under my care with 13 children, he could recognize how her father sounded differently because due to his slapping feet when he walked up the stairs when he was 25. That woman who's now 80 could look at her grandchildren with 100% certainty and great-grandchildren and make a diagnosis of CMT because she's seen so much CMT in her family. So the woman that I mentioned, her first complaint really was not being able to wear 4-inch heels when she was 25. There are old terms dating back to the 1890s describing severe CMT such as Dejer-Sotter's disease. Autosomal recessive is often more severe, not always. X-linked recessive CMT is often but not always less severe in women. Very few people become wheelchair bound. Very few people have problems breathing or speaking, although I ask all patients, are you short of breath? Has your voice changed? While it's a distal disease of the hands and feet before it becomes proximal, foot drop and all this weakness can lead to scoliosis, knee pain, hip dysplasia, and hip pain. We talked about respiratory problems and vocal cord problems. Rarely people have upper motor neuron signs. It should be just the peripheral nervous system. Sometimes the spinal cord can be involved, sometimes cognition. And going back to amyloidosis, heart, bladder, and bowel can be involved. Vision in this condition as well as in some others. Kind of the next slide, please. So one thing that we have focused on recently is that even for conditions where there is a clearly defined causative genetic abnormality, we still must account for the fact that identical twins, fraternal twins, siblings, parents can differ quite dramatically in the severity of their condition. There can be environmental factors to account for that, but most genes where one gene, most conditions where one gene determines whether you have the condition are also modifiable by specifics in other genes. And in 2019, one such modifying gene was identified, and I actually do quite a bit of research on similar phenomena. Can I have the next slide, please? So how do we approach a patient for CMT? I approach them exactly the same way as a patient where I suspect an acquired neuropathy. Patients require a complete workup for other causes. As they say in German, you can have fleas on lice. You can have two different conditions at the same time that have the same outcome. So so I ask patients, do you faint? Do you sweat differently? Do you have bladder problems, bowel problems, sexual problems? I look for asymmetry. Typically, conditions that are caused by mutations affect each nerve the same, but there are important exceptions to that. People, for instance, patients who have bilateral carpal tunnel syndrome had Bell's palsy 10 years ago and ulnar neuropathy at the elbow. I suspect a form of CMT. I examine their skin and shoes for calluses and for unequal wear of shoes. I assess the gait safety. What's the risk of falls? What's the risk of head injury and fractures due to falls? I often order bone densitometry because the internist often doesn't think about it or only orders it in people in their 70s. I order it for people in their 40s who fall often, in men and women. I assess the distal most muscle bulk. I order some 20 tests, routine lab tests to look for other causes. Those include infections, HIV, hepatitis C, syphilis, Lyme disease. I look for vitamin deficiencies and toxicities. Many people, I'm sure also in the audience, think that vitamins are good for you even if you don't have vitamin deficiencies. Vitamin B6 is notorious for being toxic in people's blood because people pop pills that contain it. And vitamin B6 toxicity can cause neuropathy just as its lack can cause neuropathy. I do a lot of genetic testing. Probably send genetic tests off once or twice a week. Electrical studies have become less important. We still do quite a lot of them, but they're less important because we can get the genetic test and get a definitive diagnosis in many people. Same thing for biopsies. We still occasionally get sural nerve biopsies, but it's pretty rare. And I evaluate patients for depression and anxiety and address that with my team of psychologists. Next slide, please. So genetic counseling is important, and I think it's important to realize that most of your doctors are so far removed from learning about genetics and molecular biology and how genes function, they do not understand the tests that they order. I personally never use genetic counselors because I've trained myself over the last 30 years to fully understand how to interpret genetic test results. I do a lot of research on that. And so people need to understand ahead of time what is the possible outcome of a genetic test. People need to understand how to interpret results. And when it makes sense to test other family members. So for instance, if you have an autosomal recessive condition, your parents didn't have any condition, although they passed on one bad copy of their genes, of their chromosomes to you, and therefore you have a condition. There's no need to test your children unless you marry your cousin, because the children can only inherit your bad copy of the gene, but odds are 1,000,000 to 1 that your partner does not have a mutation in the same gene. Whereas if I've had patients who came to me after learning from amniocentesis, because they were in their 40s when they had their first child, that their baby had CMT, and then they had them self-tested. And of course, one also needs to talk about opportunities to avoid having an affected child through in vitro fertilization. That is now routine. It is done by collecting eggs from the woman, incubating the eggs, typically more than one, with the sperm from the partner, letting the eggs divide a couple of times in a petri dish, testing one cell from that embryo for the genetic mutation, and then implanting into the woman's womb only those fertilized eggs that don't have the mutation. It has become no big deal. It's pretty much routine in many places. Of course, it requires that a person knows what their genetic mutation is. Can I have the next slide, please? So how does genetic testing work? When I studied that family in the United States, on a Sunday afternoon, I drew blood on 50 people from ages 5 to 70. It was quite stressful because I knew I couldn't screw up and mislabel them. Now it's much easier. As you can see here, one can use a cotton swab, rub it on each cheek on the inside 10 times, do that twice, and put it into a tube and ship it off. Alternatively, one can have a person depose a teaspoon of saliva in a tube, and one ships that off. It works well in 90% of instances. Sometimes there are not enough cells in the saliva, and then one has to go to a blood test. It can be done at home, but it just needs to be shipped off immediately. We usually do it in the office, and you get results in 2 to 4 weeks. It's pretty simple. Can I have the next slide, please? What's not so simple is how to interpret them. Just like people in the audience have brown-eyed, blue eyes, have curls or not, or straight hair, have dark hair or blonde, all of that is determined by genes. And there are there is no disease-causing mutation that makes people have black hair versus blonde hair. It's normal variation. That's true for all genes. So we find changes in genes where a person's particular gene deviates from what is known about the majority of people, but that is not a disease-causing mutation. And if you look at reports, you may find the ultimate conclusion being pathogenic, definitely causes disease, likely pathogenic, variant of unknown significance, or likely benign, or definitely benign. And of course, if a person has a pathogenic mutation in one gene, but for there to be disease requires 2 bad genes, as an autosomal recessive, that one pathogenic mutation, which is also called heterozygous, is irrelevant to the disease. If that person has a neuropathy, it's not from that one mutation. And what I see in my practice is that lots of physicians give patients vague answers because they themselves don't understand how to interpret these reports. And then patients walk away from that visit and have concluded the doctor said, I may have CMT, when truly it's pretty clear that they do not have CMT. And that situation should never abrogate the search for other causes of neuropathy that may very well be treatable. So if people go to CMT specialists, they will not have such vague answers that may be misleading. Can I have the next slide, please? So we talked about genetic counseling, in vitro fertilization. There's obviously also options for in vitro fertilization with donated eggs or sperm. There's surrogacy, there's adoption. And the care of patients with CMT is quite complex. For children, they need to be the care of a pediatrician. For people above a certain age who are at risk for medication side effects, they should be under the care of a geriatrician in addition to the neuromuscular specialists. Patients may need to see a podiatrist because of calluses. Some patients benefit from ankle surgery, which can be done by highly specialized podiatrists or orthopedists. School nurses and coaches need to be informed. Kids need to have adjusted learning plans so they have more time to get from class to class if they have foot drop. They may need dispensation to use elevators rather than the stairs, and they may need to have dispensation for adjusted physical education. Neurophysiologists play a role who can do electrical studies, physical therapy, occupational therapy, orthotists that design ankle braces, physiatrists, and counseling psychologists all form part of the team. Can I have the next slide, please? Health behavior is a big topic of conversation. If I have patients with respiratory compromise, I urge them to get all vaccination, annual flu shots, annual COVID shot, RSV vaccination, shingles vaccination, and pneumonia vaccination. The heavier a person is with an abnormal body mass index, the higher their center of gravity above the ground. That in itself is a risk for falls. Sedentary lifestyle weakens trunk muscles. You can't do much through exercise about weak feet and ankles or fingers. You can do a lot in terms of exercise for your shoulder girdle, your trunk muscles, your chest, your abdominal muscles, and your thigh muscles. Exercise is a big part, and I've referred a bunch of patients who can afford it to personal trainers, and of course I refer lots of patients to physical therapists. Patients who have trouble using their hands can use assistive devices, and we'll show some of them offered by occupational therapy. Patients often take tons of medications, such as antihistamines for sleep. They can increase fall risk. Alcohol consumption can be a significant problem because if you're tipsy, you're more likely to fall. And if you drink 5 drinks a night, alcohol will damage your nerves in addition to CMT. Obesity is a risk factor for diabetes. Having diabetes and hereditary neuropathy will make the nerves dramatically worse. Taking medications that can damage nerves can be a problem, and your doctors all need to be aware of the fact that you have CMT. Platinum makes for great wedding rings and other jewelry, but don't swallow it for cancer. Some patients have to take platinum-containing drugs for cancer, so this is a risk-benefit analysis that needs to be done by the patient with the oncologist for cancer. Respiratory insufficiency needs to be treated. I work with neuromuscular pulmonologists. I had a patient with CMT and phrenic nerve palsy who had a surgery on her diaphragm and now for the first time can lie flat in bed and can exercise. And of course, vocational rehabilitation entitlements can allow people to stay in the workforce. Being close to a bathroom, having disabled parking spots close to the entrance, being able to use a wheelchair at work, having a dictation software if your hands are weak, all of that can be very helpful. And in terms of surgery, can I have the next slide, please? We'll get to that in a second. So these are some of the tools that can help people with weak hands function well, whether it's grasping silverware in the kitchen for eating, toothbrushes, other tools, pens, and so forth. They can be ordered by your occupational therapist, or you can buy them online. Can I have the next slide, please? People with foot drop benefit from ankle braces. From left to right, the left one can be off the shelf, non-custom made, cheap. The black one facing to the left is much more expensive, costs a couple of $100, is typically covered by insurance. The fancy green and blue one, you have to fly to Las Vegas. If you're lucky, you can pay for it with your winnings because it costs $15,000, $20,000. I work with a person, and Ms. Colbert knows that person, who walked the New York Marathon wearing these. They convert kinetic energy into high potential energy and vice versa. Can make a huge difference, extremely expensive. And some people use wheelchairs. Can I have the next slide, please? And the next slide. So this is a patient with severe foot drop, as you can see in the upper panel. And in the lower panel, you can see all the hardware that the orthopedic foot and ankle surgeon that I work with put in this person, cut lots of bones. And I can have the next slide, please. And that's the before and after picture. Foot drop versus much improved ambulation and so forth. So that's an option that I discuss with my patients. Can I have the next slide, please? So the approaches to treat CMT with drugs. I've completed my third trial, and none of these drugs will make it to the market. One company went bankrupt over that trial. It's difficult. So in CMT1A, there is an increase in the number of genes making a normal protein. So the approach is to try to silence expression of that gene so as to reduce the amount of protein that's made from 150% towards 100%. There are different ways of doing that. The drugs we tried were pills that, or it was a liquid cocktail, but there's also RNA gene silencing approaches. They've been developed in rodents. I'm working with a group in France that thinks that injecting this drug into the nerves of people might work. So there are different approaches. Similarly, we can introduce normal genes into cells. This is being tried for CMT1X. There are also thoughts way off into the future to use CRISPR technology to correct genetic abnormalities that you might have heard about. There's one trial that I'm involved with right now that does not change the ultimate outcome of CMT, but can improve symptoms by making diseased nerves conduct electricity better. So that's the NMD trial. Can I have the next slide? And going to the transthyretin amyloid neuropathy, where there is, as we showed earlier, protein accumulation of toxic protein. So how can one prevent the manifestations, which can be very serious when it affects the heart, of those mutations? So one can stabilize the abnormal single protein units and prevent them from forming the fibrils that damage the heart, the kidneys, and the nerves. Alternatively, since this is autosomal dominant, meaning that people have one normal copy of the gene and one abnormal copy of the gene, one can silence the abnormal gene and thereby treat people. So those are two mechanisms that have been that are represented by drugs that have been FDA approved for quite a number of years, and there are several such drugs on the market right now. Some of them are more specific for neuropathy and others more for the cardiac manifestations. Can I have the next slide, please? And we can stop here, and we can skip this, and I'll be happy to take questions.
Great. Thank you so much, Dr. Thomas. Lots of questions did come in, so I want to take the next 10 or so minutes to kind of cover some of the things. But your presentation was extremely thorough, so thank you again. Curious if you could expand more on the difference between CMT symptoms and amyloidosis symptoms, including maybe if there's a difference in the onset of age, or I guess, again,
Sure.
what the primary difference is between CMT and HTTR are.
So you don't know much about the gene unless you know the specific mutation. And many genes can have hundreds, thousands different mutations.
Yeah.
Depending on the mutation, a person can look very different from another person with a mutation in the same gene. That's true for transthyretin as well. There are specific mutations that mostly affect the nerves, and there are mutations that mostly affect the heart. I've been testing for transthyretin mutations for the last 6-7 years, 75 patients per year. I have yet to find a person with a transthyretin mutation causing neuropathy. I have 2 patients under my care that were referred by their cardiologist. They have a mutation, but that mutation is very unlikely to cause neuropathy. I tested those people intensely with nerve conduction studies, and those patients don't have a neuropathy. So it very much depends on the mutation.
Would it be possible for you to expand a little bit more on the signs and symptoms of amyloidosis?
So the neuropathy is essentially identical to the range of neuropathic symptoms of any other form of neuropathy. So there's nothing specific, which means that you have to have a suspicion for amyloidosis just as much as you have to have a suspicion for a patient who presents with neuropathy for any other genetic mutation. The other signs and symptoms are affection of joints, especially the shoulders, kidneys, sexual function, bladder function, and of course the heart. Patients can present with bilateral carpal tunnel syndrome. But of course, carpal tunnel syndrome is one of the most common types of neuropathy, often caused by people who work with their hands a lot, people who knit professionally. And there are other hereditary neuropathies that can cause bilateral carpal tunnel. The heart manifestations can be heart failure or irregular heartbeats.
Okay. So what kind of questions should a patient ask if their genetic counselor, ask of their genetic counselor after they've learned of a variant of uncertain significance? What kind of questions do you think patients should then start probing into?
Right, so if it's of uncertain significance, it means it's irrelevant until proven otherwise. And over time, a genetics report of uncertain significance might be changed to pathogenic. That happens. And that happens if there are other people with the same mutation found to have neuropathy. That's why I often tell my patients, if you want to get more clarity, you have to do your homework. And your homework is to bring me 10 family members who have the same mutation and neuropathy, and 10 family members who don't have the mutation and don't have neuropathy. That's how I identified that new gene, by comparing the genes of people in the same 2 families with neuropathy against those without neuropathy. Now, of course, and if those 10 family members are from different generations, that's more helpful than if a person shows up with their 10 siblings. Of course, many people don't have 10 siblings. The genetic testing lab will update the ordering physician if an interpretation changes. So just this week, I got an update by email from the genetic testing company for a patient who I'd seen once or twice 4 years ago, who had a mutation identified as likely benign, and that interpretation was changed to definitely benign. It can go both ways.
Okay.
And which also means that if people change doctors, the new doctor will not get those notifications unless the doctor has the report and reaches out to the genetic testing company and tells them, of course, with the patient's written permission, that henceforth, I'm the person who needs to get those updates.
Sure. And if, would you recommend that patients do a complete gene panel if they already did maybe a partial one and they got all negative results? I mean, how vast of a panel would you recommend for folks that are interested in getting this diagnosis?
So a complete gene panel can cost $10,000, $15,000. It's not covered by insurance. Okay. More limited panels, such as from the Mayo Clinic, 200 genes, very excellent testing, costs $3,000. They'll send you the bill. You can submit it to insurance. Whether they pay for it or not is anybody's guess. Smaller panels cost much less. However, I think it's important to preface all of this by remembering that only 7% of patients with neuropathy have hereditary causes. 93% it's acquired. And if a person presents who's had 30 years of diabetes and their average blood sugar is 200, it is extremely unlikely that it's caused by anything other than diabetes. If a person, we now know how to treat HIV, but when I started practicing 30 years ago, we didn't. People with AIDS, all of them have neuropathy. And many of the HIV drugs cause neuropathy. So if a person is being treated for ovarian cancer and is on Taxol or platinum drugs, and a year later they complain of tingling in their nerves, they don't need genetic testing. We know what causes their neuropathy. So I just caution against focusing on heredity unless the acquired causes are fully explored by experts. Your internist can order a genetic test. Your internist does not have the training to evaluate you for causes of neuropathy.
That's interesting. And to your point, you had mentioned that it's only 7% of neuropathies are hereditary. Is that what you said?
Yes.
Did I? So is there a way, of those 7%, what percentages are related to CMT and which ones are related to amyloidosis?
So I referred to one of the earlier slides.
Okay.
1 in a million people have transthyretin mutations. So that's about 350 in this country. 140,000 people have other causes of hereditary neuropathy. Out of those 140,000 people, 70,000 have a duplication in the peripheral myelin protein 22, PMP22 gene, and they have CMT1A.
Okay, no, that's helpful. Well, Dr. Thomas, thank you again so much. We are pushing up against the hour. I am so sorry for some of the folks that have asked amazing questions. We're unfortunately out of time, but we'd be more than happy to answer those questions after the webinar. You know how to reach out to us. We have information on this slide right now that has our contact information. We hope you fill out the survey. We hope you enjoyed this webinar. Thank you again to Alnylam Pharmaceuticals for sponsoring us, and Dr. Thomas, your expertise today has been amazingly helpful, and can't thank you enough for that. So thank you again, everyone, for joining us today. And if there's anything else that we can help with at the Foundation for Peripheral Neuropathy, please don't hesitate to reach out. Great.
Thank you,
again.
everybody.
Thank you.
Enjoyed the meeting.
Bye-bye.